So yeah, it's amazing that this course has been going on for 13 years, and I feel very privileged to have been part of it from the beginning. The shirt that I'm wearing right now is circa 2010, the original shirt from this course. So it has a lot of nostalgia. We're going to go through complication avoidance and in adult deformity surgery, and we're just going to go through various things and various pearls that I think are relevant to help avoid the risk of getting complications. So these are my disclosures. And so the first thing I want to say is that deformity in the form of scoliosis is incredibly common. If you just look at random x-rays of the population, there's a report of scoliosis that's present in a range from 8 to 68%. So as the population ages, you can see that there's a greater percentage of people in the U.S. That is going to be aging, and as the population ages, there's just going to be greater and greater amounts of deformity. And so this is something that we're all going to face as spine surgeons, the overwhelming increase in aging populations and hence deformity. So complication avoidance in deformity surgery, it starts with the surgical indications. One of the unfortunate things about deformity surgery is that the main reason why we do it, or very often a common indication for surgery, is pain. So pain is not the only factor to consider with regard to surgical indications, because some of these surgeries that we do are overwhelmingly large, and so you got to be very careful if the main indication that you're doing is pain, because you have to very carefully document that conservative treatments have been maximized. So, curve progression, functional limitation, decreased respiratory capacity, decreased motor power, those are pretty clear-cut and concrete indications, and so no one will fault you for doing a big deformity surgery for those criteria. But it's important to look at modifying factors such as bone quality, frailty, and cardiac disease as issues that can increase the risk of developing complications. So complication avoidance also is tightly intertwined with radiographic evaluation and careful preoperative assessment. We really need to evaluate the pelvic incidence in all of our patients, as that serves as the foundation of our lumbar lordosis. And we want to look at the overall sagittal imbalance and the degree to which we are creating compensatory mechanisms to help ourselves stand up straight. It's critical to really carefully evaluate the degree of compensation and the loss of lordosis, because this is the foundation for which we decide how much correction is necessary. And the other thing that's very critical is to evaluate how stiff the curve is. You may make calculations of how much curvature you need and how much of a correction you need based on standing radiographs, yet when the patient lays down, the amount of curvature may be different. And if the patient has a flexible deformity, you may potentially be at risk of overestimating the amount of correction that you need. So you got to make sure that you're not making your goals of surgery purely based on the standing films. There's an important consideration with regard to flexibility of the curve and whether or not it changes when they lay flat. So we all know that the pelvic incidence is the foundation for spine alignment, and this is well established. I just want to drive that home. It's very critical to measure that pelvic incidence in everybody to get better understanding of what their harmonious curvature should be. So pelvic tilt, as we discussed earlier, is also of critical importance because you want to see to what degree is this patient compensating. These are two patients with the same degrees of lumbar lordosis. However, one of them is grossly off, and the other one is properly aligned. You can appreciate that the patient on the left has a pelvic incidence of 35, whereas the patient on the right has a pelvic incidence of 76. Yet they both have approximately 40 degrees of lumbar lordosis. So measuring the amount of lumbar lordosis on its own obviously is insufficient in seeing whether or not a patient is harmonious. So the relevant feature of this slide is the fact that the pelvic tilt plays a substantial role in the ability of the patient to stand straight and have their chest and upper body positioned over their pelvis. These are actually the same 3 exact radiographs in the same patient. And you can see that on the left, the sagittal imbalance is 22, and on the right, the sagittal balance is normal. The only difference is the amount of pelvic retroversion. And so you can see the overwhelming ability of a patient to compensate for sagittal imbalance based on the power of pelvic tilt. So when evaluating your standing radiographs, it's very important to look at the pelvic tilt and see what that patient's doing with their pelvic retroversion, and that will play a role in helping you determine your surgical goals. So it still remains that the standard for deformity surgery is open surgery. This gives you the greatest latitude and the greatest access to decompress the neural elements. The problem with open surgery, however, is that there's a lot of recovery period. You have a lot of risk for complications, risk for nerve injuries. The extensive blood loss leads to other downstream sequelae such as transfusions, potential risk for stroke, pneumonia, delirium, etc. So the gold standard of deformity surgery is cursed with all of these potential risks of complications. David.
Charlie, what complication rate do you quote your patients for T2 to the pelvis?
100%.
Yeah.
Yeah, so there's a 100% risk of complications. You have to counsel those patients adequately. And for this reason, patient selection plays a critical role in complication avoidance. This is something that should be a several-month process. Weight reduction strategy is important. Nutrition is important. Preoperative physical therapy is important. You want to get medical clearance for patients who have history of cardiac diseases and other issues such as thrombosis. Bone quality is obviously important. Frailty is important. All of these factors play a role in your ability to predict whether or not these patients are going to have a complication. Does this patient have at least a 5-year life expectancy? What is the social support system? These are questions that need to be asked. Is the patient 75 years old, and do they have any children that are involved in their care? Do they have a significant other that can help with their care? These are all things that can potentially sway you in one direction or the other with regard to whether or not to recommend a major intervention. So it's key that Schwab's grades of destabilization are noted that with advanced degrees of destabilization, there's advanced risks of complication. This happens to be a paper that I wrote several years ago from the Scoliosis Research Society database on scoliosis morbidity. And the major complication rate in this patient population was 13.4. I would have to say that's a gross underestimate of what the real major complication rate is, because this was a retrospective database with a recall of information, and so very often that's something that's not going to be recalled, and so complication rates in reality are significantly higher. As you can see, there's a broad spectrum of complications that were evaluated, but the most important thing about a potential complication in this patient population is the risk of a neurological deficit. And that increased with the presence or absence of an osteotomy. Patients with osteotomies had higher incidences of neurological deficit. Another paper from the SRS database is demonstrated here, again showing that as you progress from Smith-Peterson osteotomy to pedicle subtraction osteotomy to vertebral column resection, there's a graded increased risk of complications with 61% complication risk in the vertebral column resection group. So as this follows the Schwab destabilization, as you go further along to grade 6, the complication rates go up tremendously. So it turns out that for years we were making our calculations to correct lumbar lordosis using standing scoliosis x-rays. And I think we have been having our set goals based on the pelvic incidence in the lumbar lordosis plus or minus 10. That was the foundation for years. But as we learned more, we realized that our correction goals should be different based on patient age. And this paper from 2016 from the ISSG demonstrates for patients over 75 years of age, the goal should be closer to 8 centimeters of positive sagittal balance as opposed to 4 centimeters for the younger groups. Another recent article from the ISSG demonstrates a age-adjusted equation that you can use to determine the goal of lumbar lordosis. How much lumbar lordosis do you actually need? And you can actually calculate it. This was a regression analysis based on a population of patients of various ages, and you take into account the thoracic kyphosis, their age, and their pelvic incidence, and this regression analysis facilitated a calculation of what your potential correction goals should be. So we're going to go through various different cases and go from maximal invasiveness to less invasiveness and look at clinical pearls for each one. This particular patient is a patient who was off sagittally, and you can see that she was compensating with a significant increased pelvic tilt, but in addition to that, she had approximately 0 degrees of lumbar lordosis. Superimposed on all of these problems, she had a bad sacral fracture. So this patient required a plan to address the sacral fracture because she was having incontinence. But in addition, she had a profoundly abnormal sagittal imbalance. And the plan for her at the time...
Charlie, can you go back one slide? Or one more, sorry. The likelihood of this being a rational decision is 0. It's impossible for this to translate into success. So this is an error in concept. And I don't know the order in which these things were performed, but I can't even justify either order. Like, I can't even come up with a rational way to say, oh, this makes sense in relation to the other.
Yeah, I can give you a quick history. So this patient started out with a T2 to pelvis, developed a pseudoarthrosis at L2-3, she was solidly fused distal to L3 and distally. And I guess the referring doctor did a lateral fusion at L2-3 to deal with the pseudoarthrosis and took out the rest of the hardware distally.
Yeah. It was in this very room about 10 or 11 years ago that Larry Lenke gave a gorgeous lecture about the long-term value of instrumentation, and that just because you have a bony arthrodesis does not mean that you stop remodeling.
Yes.
And so when you take metal out of a living organism, there are consequences for that. And removing the instrumentation in the lower lumbar spine down into the sacrum
was a big mistake.
It was a huge mistake.
I agree. This was a tragic mistake for this unfortunate patient. So it's, as you can see, because of that absence of instrumentation, she developed this horrible sacral fracture, developed incontinence of urine and bowel. So she had a twofold problem. She had this unstable sacral fracture, and superimposed on that, she had this horrible sagittal imbalance. She had scar tissue down at the bottom. And I was not really, I didn't have good access to the L2 and L3 pedicles because of the L2 anterior surgery. So I ended up doing an L2 PSO. Important pearls about the PSO in terms of complication avoidance is you want to make sure you can see both nerve roots. Once you've resected the pedicle and you close the wedge, you want bone to be touching bone, but you also want these nerve roots to be unrestricted. And it's very important after the closure is done to make sure that the nerve roots are not getting pushed down by bone that sort of changes its position as a result of the closure of the wedge. The other thing about a PSO like this is that the dura has to be stripped free of scar tissue. If you close down the wedge on dura that is scarred down, the redundant dura is going to cause mass effect. And so you really have to have clean dura in order to do this surgery safely. And that's consistent with what Jens was saying earlier. You don't want to have redundancy of the posterior elements, especially when they're scarred down, and you're better off having an anterior lengthening procedure. So in this case, you can see with that correction, she was able to get a restoration of her sagittal alignment. And this essentially was a posterior column shortening, but at the same time, she had a release of the anterior column because of the brittle bone that was there. This is one of these situations where the temporary rod was very critical because she had a break in the anterior column during the PSO. So the reason why I think such a dramatic correction was achieved was because of the anterior break that was present. And so having the temporary rod is critical, especially at the conus level, because had that not been present, she would have gotten even more compromised. So this depicts here the three-column osteotomy, which is pure posterior column shortening. But this is kind of a melange between the two. It's an anterior column lengthening and posterior column shortening at the same time. And that's kind of like the happy medium, because sometimes it's not one or the other. Sometimes it's a little bit of both. So depicted here is a correction. This patient has a normal sagittal alignment right now. And you can see 24 months post-op, this is how she looks, and she's in better spirits. She's regained some of her urinary incontinence. She's had resolution of the fracture. This is healed in a nice way. But the problem with her was that she was falling backwards. She was so corrected, and that I think has to do with the fact that she had that loose anterior column, so we had a lot of leverage, and perhaps too much lumbar lordosis was given to her, and her sagittal, she just wasn't used to that sagittal position, and she kept on falling backwards. So as a result, what we had to do was yet another 3-column osteotomy, but the difference was to extend the posterior column and create a distraction at the level of the L4 pedicles. So she had an L4 3-column osteotomy it was a distractive maneuver as opposed to a shortening maneuver to pitch her forward slightly, and that actually worked. So you can compare this picture to the right is her sagittal alignment when she's upright prior to the L4 distraction osteotomy. On the left is the L4 distraction osteotomy, and you can see that this pitched her forward just the right amount. So a 74-year-old physician with profound sagittal imbalance. In the past, this would be someone who I would think that may need a T4 to pelvis. But learning from the fact that our goals should be simply to get the patient closer to 8 centimeters instead of 4 centimeters, our correction goals are not as significant in this patient, and you can appreciate this is a partial correction, and this patient is actually 6 years out and is doing very well and still maintains his alignment in this fashion without any progression of imbalance. And when measured out, this is about 8 to 9 centimeters positive, which is his happy medium. This is what he was before. So this follows that Lafarge age-guided correction principle. For this gentleman was 74 years old.
Yeah, but I noticed you left the rod long to accommodate the easy extension.
That is true. So other factors that I can quickly mention is the intradiscal osteotomy, like Rod was talking about earlier, and Jens has popularized this as well. You can attenuate the anterior longitudinal ligament. This may be useful in a setting of scarred dura where you can't do a PSO. So you can. This was described also by Dr. Sweet in this paper from 2015. They described this technique of releasing the disc and releasing the ALL from the posterior approach. We reviewed our series. Dr. Hahn in the audience was the first author of this paper. Both myself and Dr. Ludwig used the release of the anterior longitudinal ligament from the posterior approach as an alternative to a 3-column osteotomy, particularly in patients that have scarred dura. And so you can have a partial or complete release depending upon the degree to which you need to loosen things up. This just depicts examples of this is a situation where we attenuated and weakened the ALL in order to stretch it. And another demonstration here, not a complete release, but a partial release. And you can see yet another example, just a partial release. And you can, if you weaken the ALL with blunt dilators, you can achieve similar corrections that you would achieve from a PSO without the blood loss. So, bottom line, there are risks associated with this method, and blunt instruments are very important. And you don't want to use sharp instruments for fear of injury to the vasculature in the front. So it's important to look at spinal complications in deformity surgery. They have substantial implications on the future of our field. A recent article shows that there's a significant increase in cost when complications occur. The most common complication is infection, and that can increase the cost substantially. They're 2 to 3 times greater than those without complications, and it's already a very pricey procedure. So Just wanted to conclude that there's a broad spectrum of treatment options. The best strategy depends on the patient's pathology, but also the experience of the surgeon. And patient selection plays a substantial role, but the reminder is that complication rates are very high. And your correction goals should be based on what the patient needs and not based on pure correction of the films. When you're older, you can get away with and actually have better results with smaller correction goals. So just a quick pitch for the spine section meeting in 2023, March 16th through 19th in Miami Beach. Any questions?
Hi, I'm Evan Nye come from Cedars-Sinai, fourth year ortho. When you're going posteriorly and you realize the dura is scarred down, and so you're going to try an AL release, do you prefer to do it in the back, or do you sometimes close and go from the side or anteriorly?
So my initial attempt is always through the back. So there's always going to be a fascial or a plane of dissection that you can utilize. Most of these patients have facet joints that have not been taken, and so you can get a fresh dural plane and get a safe entry into the disc space. It's relatively rare for me not to be able to get an attenuation of the ALL, but if it's not achieved, then sometimes going in from the side is necessary, or from the front.
Hi, it's Jared from McGill again. So for overcorrection and avoiding that, do you find you're going to those age-adjusted values now, or do you still put people even less than that if they've really have a lot of correction to do? What's your degree of moving to that point, to that age-adjusted number?
So, yeah, I'm moving more and more to those age-adjusted levels because in the setting of poor bone quality, there are more and more patients that are needing surgery. I think PJK is very often a result of poor bone quality and overcorrection. And I think I think you're much better off undercorrecting and having an adequate decompression of the nerves. You can always go back and do more correction. That's something that I've sort of taught myself over the years, is that when in doubt, err on the side of undercorrecting and over decompressing. And that way you will, at the very least, get a happy patient who has nerves that have been decompressed, and they'll be forever grateful, even if they're bent forward a little. But if you're older, being bent forward a little is actually their natural position.
How about Charlie? One thing that's not talked a lot about is bone density. In terms of do you use DEXA, Hounsfield units? What's your cutoff?
So we order DEXA scans, but I think nowadays a very good surrogate is the Hounsfield unit measurements that you can get from any CT scan. I'm forgetting the number for the cutoff. Is it 12 for the Hounsfield units?
Usually, between 60 and 80, you start to get osteoporosis.
So the Hounsfield unit cutoff, I think, is increasingly getting popularized due to frequently it's difficult to maybe get a DEXA scan authorized, because sometimes insurance companies will only authorize a DEXA scan once every 3 or 4 years. So I think getting calculating the bone density through that surrogate measure is actually very useful.
So do you get both?
I get a DEXA scan when I can, but otherwise, all my patients get a CT scan. So I certainly look at Hounsfield units.
And then how about, let's say if they're osteoporotic, like that case you showed, what do? Do you say, hey, sorry, I can't do your surgery?
Well, it depends. Sometimes I'll use cement augmentation. If the patient has a neurological deficit, I'll still proceed with surgery as long as they're counseled about the risks. If they're smokers and osteoporotic, sometimes we say no.
Yeah. And then how about, so let's say, do you sometimes use cement, or what are some other tricks?
So, I have another talk tomorrow.
Okay, great.
Show PJK, so I'm going to save some of it for that.
Okay, awesome. Thanks, Charlie. So we're going to...